Welcome to a community update from the Department of Senior Affairs. I'm your host, Ed Nunez. Today's title of the show is A Realistic Look at Treatment Expectations, especially at the end of life. And with us to talk about that, and once again, our special guest is Dr. Ann Simpson, Director of the UNM School of Medicine Institute for Ethics, and also Catherine Combs, Licensed Independent Social Worker, Education and Outreach Manager at the UNM School of Medicine Institute for Ethics. Ladies, thanks so much for being our guests.
Thank you for having us.
You bet.
Thank
you bet.
you.
And I guess the first question, and I'm going to ask Dr. Simpson, you had mentioned this before we got on, is why are we doing this?
Absolutely. We're doing this primarily because when people are in a crisis mode, particularly when they themselves or someone they love are in a situation, could be an accident, it could be just that it is at the end of their life, and a lot of emotions are at play, and people can't think to process information about treatment options and about the kinds of decisions that they have to make. So it's a difficult time. So we educate people beforehand. Hopefully they will have information that they could process when they do find themselves in a crisis, either themselves or someone they care about.
I think one of those things that you mentioned at the end of life, I mean, crisis could have you really at the end of your life right at that particular moment, meaning that's the end of life and there's no time to process information. The other part is you might be able to do that. We've all, my father passed away after being diagnosed with cancer, and it took him 3 months, and we had some time to process that, but not everybody does. And
right.
If it's the end of your life, and meaning the end of your life, adrenaline surges and things like that.
Right.
But I guess each situation at the end of your life is different.
Right, and sometimes it's not even quite at the end, but it's the time when you have to make decisions, in particular about treatment options. And so, and even if it's at the end of life, people don't understand what is meant when options are presented about hospice, palliative medicine, those kinds of things. So that's why we want to make sure people have a chance to explore, ask questions, and try to understand what some options may be.
That's very important. Catherine, how does one distinguish, what do you mean by realistic treatment expectations? What do you mean by that?
Oftentimes, we've seen on TV shows where miracles happen. The TV shows, Grey's Anatomy. Everybody lives. Somebody goes into cardiac arrest and they do CPR and they're up and talking in bed. A few minutes later. And so we have reached a point in our lives with all of the medical advances that have been made over the last 60 to 70 years, all the access to vaccinations, transplant potential. We've gotten an idea in our heads, I think, that we can do everything and be saved and basically be immortal, and that's not the case. Not everyone can survive whatever has happened to their body, whether it's a heart attack, cardiac stroke, or a horrible accident. And people need to understand that we all are dying, we all are born and start dying right away. So we have to have realistic expectations of what can be done and what can't be done, what would not be appropriate medical treatment, appropriate medical care.
Do you care to expand on that at all? I think one of the things is there's no question people are living longer, but it's not as if we're living towards Adam's age in the Old Testament, 800 years old, or Noah, or we're not going to live like that. And I think you're right. People expect a little bit more, and nobody's immortal. You're right. The minute you're born to die. There's no doubt about that. And you saying that as soon as we're die a little bit more every day. True. But would you care to expand upon the treatment? Some that's appropriate and some that's not. Do you care to expand upon that?
Well, I come a lot from the perspective of serving on the University Hospital Ethics Committee along with Dr. Simpson, and we will be called for consults on patients where maybe the family members, if the patient isn't able to voice their treatment decisions because they're unconscious or in a coma, the family is saying, you've got to do everything. You've got to save them. Say, you know, I want them put on dialysis when the kidneys are never going to regain function, or I want them put on a transplant list to get a new liver when the person's other organs are already dying. They're shutting down. We frequently we want everything done said to us. And it's just because they're speaking from the heart as opposed to from the head and being unable to process what medical information they have been given. And they may not understand the medical information they've been given. A person may have somehow, in talking to them, one of the providers mentioned a possible surgery that might be of benefit, but the reality is it won't. They can't, the person wouldn't be able to survive the surgery. They are so debilitated. But they had that one hope kind of planted in their brain, and so they go with that.
I think the other thing too, though, it's at the end of your life, I think, you know, when you think about that, and we all know we're going to eventually meet, everybody's going to pass away. But I think at the same time, you know, it might be family, selfish reasons. They want to keep their loved one there. There's no doubt about that. The other thing is, you know, they're thinking about passing away, and, you know, I'm 52 now, I know it's going to happen, but nobody wants that. So, you know, if you're a fighter, you want to try everything, but you're saying, let's be realistic about the treatment that is offered, because really you're probably, in a lot of cases, prolonging more painfully the inevitable.
Right.
Correct.
And I also want to add to that is sometimes people bring to the table their own ideas of treatments and something that they heard about from elsewhere, and asking that be tried when in fact it is not appropriate to try that, because people forget that the way we all look different on the outside, our internal system is different as well. So something may have worked for someone at a particular time and place, but it doesn't mean it'll work for the person that is currently the patient. And in particular, if you look at someone who is older, they don't have the reserves that a younger person has. And so having people, educating them beforehand to help them to understand that they may be faced with this, and how do you sort of step back, think about it, and ask the questions. Because even if you're under stress, if we teach people that take a breath and then maybe be able to think about it, because we had a situation where a woman was suddenly, something happened, and she's suddenly terminal. And she has adult children, and one of her adult children said, I just want her to get better so I can take her shopping. She asked me to take her shopping, and I didn't do it. I just want her to get better so that can happen. That was not going to happen at all. And so helping people think about different scenarios and to think about the difference between treatment and care. Because in the healthcare system, we always care, but some treatments are not appropriate.
Well, think logically, rationally, objectively, and that's hard to do. It's very hard to do, let's be honest.
Right,
when you know your loved one is involved, and you know you want. I remember when they saw that for my dad. I was 28, and I thought he was going to get better. You know, I was still young, and he didn't. And you know, I still miss him every day. Every day, but. Like you said, no, those things, you were all born, unfortunately, to pass away, but that's why we're doing the show. The next question is, how does one distinguish between treatment and care?
The difference is care is something that we always provide. We're always taking care and providing care for people. And even if we're using different treatment modalities, we're still providing care if it's an intensive surgical procedure. We're still providing care if it's intensive care unit interventions. But we're still providing care if it's palliative, if it's hospice. And there's a difference between the palliative and the hospice. Hospice is a treatment modality that is provided when people are terminally dying. They are at the end of their life. People who practice hospice also have added training, just as you have practicing geriatrics, or if you decide to go into cardiology or pulmonary medicine. Hospice is added training so that you learn how to treat people when they are dying, but it's still caring. Every one of those modalities is caring. Everyone in the healthcare system goes in because we want to care for people. So we always provide the care, but sometimes we use the term treatment and care interchangeably, and healthcare professionals do the same thing. And I think that has led to some distress when people will say, we don't want to continue health care. When what they mean is we don't want to continue this particular treatment. It's time to change this treatment for something that is more supportive of the person, because treatments carry danger with them as well. Sometimes side effects.
Right, right. The other thing you mentioned was hospice care, and what was the other care that you mentioned?
Palliative
Can you
care.
explain that? Because I know hospice I'm familiar with, but
Right.
I don't think everybody else is.
Right.
The other care.
Okay, so palliative care is something when there is no cure, but we're still treating when there's no cure. We're still taking care. A classic example that I use is diabetes. Many people will not be cured of their diabetes. Some people will cure themselves through exercise, diet. They will get rid of their diabetes. Other people won't be able to do that, and their diabetes will continue. It's not being cured, it's being treated palliatively. And palliatively, hopefully, will prevent the progression to worse conditions. But either way, they're still being treated palliatively.
Okay.
So-
Mainstream term yet or not?
It is, but people think of it more along the lines as closely related to hospice, where hospice is care at the end of life. You are dying, we are taking care of you so that you have a comfortable, supportive death. Palliative medicine still offers its level of comfort, but there is no cure for what you have, but we're going to treat you, and you may have an even long life, but your condition is not curable at this point. We don't have the medication, whatever, to cure it, but we can treat you palliatively.
Okay, let me ask you this. Was that an example? Would that be Magic Johnson? I mean, when he got the HIV virus,
Yes.
everyone thought it was a death sentence, and he's still here, what is it, almost 25 years later?
Right, palliative. He
Okay, all
is
right.
because it's not, I think people are hesitant to say he's absolutely been cured.
Right.
But he's being treated. And
He still
so,
looks healthy.
yes,
You know?
So a lot of our palliative treatments, people are healthy, but it's because they're being palliated and there is no cure for what they have.
I see. Now, the terms treatment and care, are they used interchangeably? I think you mentioned they were.
They are, but really they shouldn't be, because that, I think, causes a lot of fears. Kathy and I have seen when we do ethics consults, people, when they hear someone say, we don't want to give you this care, when they're saying this particular treatment, and usually it's that not that they're saying we don't want to, but this particular treatment is inappropriate. So they're saying we don't want to continue this treatment because, number one, it's at a point where it's causing more harm than good. People don't recognize that a lot of the treatments we use, some antibiotics, can destroy your kidneys. They can destroy other organ systems. So there comes a point in time when it's a matter of continuing to harm a body. Sometimes the body has been given all that medical science has to offer it, and it is the time to change the treatment plan to one of hospice, because everything we've given it is not curative, and right now the palliative measure is just to keep them comfortable, which is, if you're dying, hospice.
So treatment and care, the difference
Yeah, so
is...
there's very different.
Oh, wow. So people would get confused about that. What have you seen as a result of the terms being used interchangeably?
That oftentimes people become afraid, and they also feel as though that they're being abandoned. And we never abandon. We always provide care, but the treatment plans may change. But we don't abandon patients, and that, I think, is the biggest fear. Would you say that?
Yeah. Care continues to be provided, just in a different way. If I've heard it once, I've heard it, hundreds of times in ethics consultations. You're just going to let them die? And it's, no, we are not going to do that. We're going to change the treatment plan from being less aggressive to one that they will be allowed to be comfortable. You can spend time with them. If they're alert and oriented, able to talk to them, be with them, provide comfort care. It's a different treatment plan. They're just not going to...
Which is provided,
let them
comfort
die.
care is pretty much provided. I wouldn't say that anybody just, for all the talk about death panels and things like that, I mean, I think pretty much everybody, not everybody, I'm sure there's cases that doesn't happen, but are treated, as you said, nobody is abandoned, I wouldn't think, at the end of
No,
us.
exactly.
Right.
You have somebody that I would think,
Right.
that you're in
Right.
a really bad rest home or somebody that, but for the most part, I would think that there's some, they're not abandoned.
No, they're
No.
not. The treatment plan is changed to one that supports the final stages of life, that supports the dying, and which is why it is an area of expertise just like cardiology is. It's sort of being able to take care of an individual to make sure that their skin isn't breaking down, to make sure that they're comfortable with their breathing and anything else, to make sure that they are offered every comfort. And there are people who are on hospice who can talk with you, and basically you're attending to them as they want. And some of them just say, I don't want to eat, but I'll eat all the ice cream and pudding you have. I don't want the other food. Well, so be it. That's what you get to have.
The other thing is treatment and care. You mentioned that. I'm sure they're also getting some counseling,
Yes.
somebody to talk to, because I haven't faced that time yet. But that's important too, because so many things are happening. You're leaving this earth, and there's regrets, there's joy, there's a lot of things.
Right.
My mother is 89, and she'll tell me, and I'm lucky to still have her. She'll tell me this periodically. I think I've lived my life. I want, I don't want to be here. And then 2 months later, she's singing and laughing again. So I think probably some people go through that, and the ones that know they're terminally ill are getting that kind of assistance to talk to people as well, right? I'm sure.
They do. There's counseling, there's spiritual counseling if people want it, but there's also the opportunity for people to engage with folks that matter to them. And sometimes what's most difficult is for your loved ones who are going to be left here to say goodbye, because the person who's leaving is often ready. And I had one of my patients who said to me, she died, she was almost 108. And so
wow.
when I took her on
Jeez,
as a
wow.
patient, she was in her late 90s, and I asked her, I said, you've taken care of yourself all of these years, what can I do for you? And she said, you must promise me you won't let them try to save me. And so I said, yes, we can do that. But her family was ready. And oftentimes families aren't ready to say goodbye. And it brings to mind what someone said to me some years ago: when you love someone, love them now. Talk with them now, be with them now. So when it's time to say goodbye, you've spent the time. You've loved that person.
I think, you know, I'll tell you what, we sure spent a lot of time with my mother. But you know this is true too, that you always question. You know, my mother's not gone, but I think you always ask yourself, or people ask themselves, did I do enough? Was I there enough? Let's face it, your loved ones, you know, if you really love them, you're close to them, you only want them here 200, 300 years, and that's unrealistic.
Exactly.
But that's why people fight to say, what can you do to save them? A lot of that's selfish reasons, of course it is. But my mom tells me this too. I just want you to be ready, she'll say. And I said, how do I get ready, Mom? Tell me, how do I get ready? Were you ready when your grandmother passed away? Were you ready? And we have that discussion all the time. How do you get ready? Tell me how to get ready. So, you know, I mean, it's going to happen, sure.
Right.
But, you know, those are tough things we all face with our loved ones in life.
And I think you're talking with her is one way to get ready. And I also think that it's important to appreciate that sometimes when loved ones are saying, I don't want them to go, I want them on a ventilator or breathing machine or something like that, the question that we try to ask is this for you or for them? What about their comfort and support? And they're never going to get out of this state. They won't be able to function in a way that matters to them. And so how do you think about the other person? It's difficult. I've lost both of my parents. It's difficult to let go, but part of it is being thoughtful about what does it mean to them?
What do they need?
Can
What
I
are their
love
needs?
them enough to let them go?
Get yourself out of the way.
Yes.
Well, that's tough to do. Because, you know, you just you want to see them leave. You want them here forever.
Exactly.
And that's just not realistic. You know, the other thing we have to ask is, do you think the use of appropriate language might lead to better informed decision making?
Absolutely. You think? Yes.
Specifically?
It's essential in that, unfortunately, medical providers have their own language. We kind of jokingly call it medicalese. It's terms and treatment options that maybe Dr. Simpson and I are pretty familiar with because we've heard them and we've been educated about them, that sort of thing. But to the normal person off the street, they may not fully understand what's being said to them by the doctors. Also factor in other cultures. Whenever we have someone who cannot speak English well, we are mandated to have an interpreter present in that person's language, somebody that is not a family member. And our goal is to make sure they understand what is being said. And a person needs to also question and keep questioning until they do fully understand what's being told to them. And if they don't understand the language, they just need to flat out say it. There's been some times in consults when the providers have made a statement that I don't understand, and I'm looking at the patient and the family members, and I can see they don't either. But they don't want to look stupid. So I'll jump in and say, excuse me, could you please tell me what that means? I don't understand it. So take a burden off of them, and then the doctors, the providers, have to realize, ooh, I need to talk a little bit different and put it in their level of understanding. Because if you don't understand what the doctors are saying, you can't make a good treatment decision.
No, that's for sure, because, you know, doctors, excuse me, do, and, you know, they talk in medical terms sometimes, and people don't understand that, and the best doctors will understand that people don't understand that and bring their discussion down to something that the common layman can understand, you know, because it's hard to do that. You know, we understand they're the most educated person in the world, but how do you get your message across and so they can understand and know what you're talking about. That's the most important thing.
You're absolutely right, because we're using this generic term as though there is one language. In medicine, there isn't. So the surgeon, if we're doing a consult with surgery, they're using terms that I don't understand. And so so we're always asking, can you please clarify? Orthopedics, they use terms I don't understand. So depending on what discipline you're in, people are using terms that the other discipline doesn't understand. So it's not just about the layperson, it's about all of us. And that's every healthcare provider does that. Be they nurse, doctor, social worker. But the other piece, the biggest piece that I think we have to work with is that it doesn't matter what your discipline is, doesn't matter what field you practice in. In our society, we can't say, Mrs. Jones, I'm sorry, but you're dying. Mrs. Jones' daughter, your mother is dying. We can't say that. We haven't learned to be able to say, you're dying. And that is part of the discussion that we need to get people to be able to articulate. We can talk about everything. Lord knows the world is filled with sex, and you can see or read about any element of it. People talk about their vacations, they talk about their different hypertension, diabetes, whatever. But everyone is going to die. But not everyone may engage in any of the others. But each and every one of us will die. But that is something we fail to be able to have a discussion about. And it doesn't matter what our discipline is.
You know, it really takes, I think we'd all agree, a special person. I couldn't do it. I know I couldn't. I would probably break down, and I just couldn't do it. I know I couldn't. Somebody, and you're right, how we articulate that and how we do that, that's two different things. We got about 2 minutes left, and I want to get this last question in. Is it appropriate to ask the providers to explain things in terms that everyone can understand? We just talked about that.
Absolutely. It absolutely is. And we do ask people to do that, and we ask that we educate patients to be able to do it, and we educate providers to do it as well. And this is across the spectrum. It doesn't matter what level of provider you are. We all need to be using language that we each understand. And important, if you're a healthcare professional, an interpreter, a family interpreting, a friend of the family interpreting is not appropriate. Because there are things, as we just said, that they may not be able to say. And so if someone in the healthcare system is using them, they may not be able to say what needs to be said.
Okay.
Will be the best one.
A realistic look at treatment expectations, especially at the end of life. Great show today, ladies. Dr. Ann Simpson, Director, UNM School of Medicine, Institute for Ethics. Catherine Combs, Licensed Independent Social Worker, Education and Outreach Manager at the UNM School of Medicine, Institute for Ethics. Ladies, thanks so much for being our guests.
Thank you.
Thank you.
Thank you for having us.
You bet. For the Department of Senior Affairs, I'm Ed Nunez.